and we should be done within 20 to 25 minutes. My name is Dr. Naweed Alzaman. I'm assistant professor endocrinology, adult endocrinology في كلية الطب جامعة طيبة. And your lecture today is about the diabetic emergencies. So in general, يعني, in our field of endocrine, there are emergencies, but there are rare. طبعا اللود of the endocrine, or mostly what we see either as an outpatient or an inpatient in terms of the medical conditions, is usually related to diabetes, and تقريبا, and this is usually 80% of the time, and 20% of the time is usually we see issues related to other endocrine issues, which includes the thyroid, pituitary, adrenals, and calcium related disorders. So if we are talking in terms of the emergency for endocrine, usually it is a diabetic emergency. Well, diabetic emergency, basically it's either one of those three, and they are life-threatening. This is why they're called emergency. So we have diabetic ketoacidosis, or the hyperosmolar hyperglycemic state, أو حتى نسميها non-ketotic hyperosmolar hyperglycemia. And the last one is hypoglycemia. Now, يعني I think by now you kind of got an idea about diabetes. It can be different types, and mostly we try to teach you as students, especially in third and fourth year, انه يعني mostly at our diabetic patients fall into one of those categories, either type 1 diabetes or type 2 diabetes, صح؟ Type 1 diabetes basically is an autoimmune condition, complete destructions the beta cells of the pancreas, which are responsible to secrete insulin. أما بالنسبة للتايب 2 لا, there is a decrease in insulin secretion بس مش complete destruction للبيتا cells. On the other hand, في type 2 there is also significant insulin resistance, and there are other pathophysiological mechanisms for type 2 that can lead to hyperglycemia, which you probably gonna hear about it in more details في سنة رابعة. So in terms of the emergencies, yani, if we talk about, and the reason I explained that subtypes of diabetes here is because mostly when you hear about diabetic ketoacidosis, or somebody's admitted in diabetic ketoacidosis or came into the emergency room with DKA, this usually happens with complete or severe insulin deficiency, which is reflecting mostly type 1 diabetic patients. Now, do we see type 2 diabetic patients with DKA? Yes, we do see them. It's very rare. It's not common as type 1, that it happens in type 1. Now, type 2, on the other hand, because they do have insulin, but it's a resistance, they might present what we call with non-ketotic hyperosmolar hyperglycemia. Now, both of those types of diabetes are prone to have or develop severe hypoglycemia, which requires assistance. يعني hypoglycemia مش الهايبوغلايسيميا اللي can be treated بكاسة عصير أو بملعقة عسل. I'm talking about severe hypoglycemia when the patient actually loses consciousness and sometimes might develop tremors and anoxic brain injury because of blood sugars going down as low as below, for example, 40s, 30s, and so on. And these are the three real diabetic emergencies. We do not usually see in the world of diabetes an emergency other than those. So if you understand the pathophysiology behind this and the how to treat it, or at least understand how many patients you might see in the when you start practicing in the fourth year, you might see a lot of patients admitted بالذات في ICU with diabetic ketoacidosis. So you got an idea from the lecture today. So I'll start my presentation with an 18-year-old male patient presented to the emergency department, basically with, has been having tiredness, fatigue, drinking a lot of canned soft drinks, and drinking anything available. Also, the patient has been visiting the toilet very frequently. The mother said that the patient might have lost some weight, maybe around 8 to 10 kilograms in the last, let's say, 3 to 4 weeks. Uh, and she was worried that, because of his teen age, so she was worried that, this kind of symptoms, اللي هو increased thirst, polyuria, polydipsia, weight loss, that he might be abusing drug. So she called an ambulance because she noticed something different. And honestly, this is the usual presentation for newly diagnosed type 1 diabetes, which is a very common thing that we are seeing in the clinic. So at least such scenario comes into my clinic at least once every 4 weeks, once every 3 weeks. It's pretty common when patients present with such symptoms, and they are clear textbook symptoms. يعني لما تيجي تسألوا المريض هيقول لكم polyuria, polydipsia, nocturia, and weight loss. So this is what we call catabolic symptoms. So on physical examination, this patient had a normal stature, lying in recovery position. He is arousable with deep pain, ولكنه breathing very quickly and deeply, and his breath smells of nail varnish remover, يعني acetone breath basically. Blood pressure is kind of low, 80/40, heart rate is elevated, his bladder is full, eyes are sunken, which basically indicates dehydration. Again, the tissue turgor is reduced and his mouth is dry. طبعا, this is a very severe case of diabetic ketoacidosis. So on further examination, as we teach you, usually we start with ABCs, airway, breathing, circulation. So basically, patient is drowsy, ولكن arousable to pain. He's hypotensive, he's tachycardic, he's dehydrated. With such condition, this patient, of course, is going to need some sort of ICU kind of care. So this patient cannot remain in ER. He should go to the ICU. طبعا, what happens is, طبعا, immediately when you see such a patient severely dehydrated, young guy, severely dehydrated, mother said that this patient has been drinking a lot of fluid. The first thing you should really check in the ER is the blood sugar, even though if the patient is not non-diabetic. طبعا وانتوا بتاخدوا history هتسألوا إذا كان البيشنت عنده أي مشاكل صحية سابقا، هتقول لكم لا, he's a healthy kid, 18 years old, and he does not have any medical conditions, and his only symptom that he's been drinking a lot, and mother noticed also weight loss. So the first thing really you should do, along with the vital signs, with kind of presentation, is really that you should check a blood glucose, and followed by, of course, you're gonna, because the patient is breathing heavily, you need to check ABGs وكده. So on urine test, his glucose was +4, and acetate, which basically indicates ketones in the urine, also were +4. Lab investigations showed basically a glucose of more than 25 millimole, which is around, let's say, around 550 milligram per deciliter. هذا التست اللي هو beta hydroxybutyrate is an acetone that is in the blood that can be highly elevated in patients who are presenting with DKA. هتسألوني, do we need that since we have مثلا acetoacetate +4 in the urine? Yes, we need to. It's better to diagnose correctly حتى ما يكون في عندنا other differential diagnoses can cause this condition. So maybe this patient was vomiting, and that's what caused him to be in acidosis, although vomiting can lead to alkalosis mostly. طبعا الصوديum is elevated, and normal is up to 144. Potassium is slightly elevated. Bicarb is low because the normal bicarb is up to 22. Creatinine is elevated. The normal creatinine is up to 80, up to 100, but 183 is kind of elevated. Osmolality is elevated, basically indicates that this patient has dehydration. لما عملوا اللي هو arterial blood gas, of course, when we look at the pH, is The normal pH is from 7.35 to 7.45. So this is 7.29. So this is acidosis. ولما شفنا CO2 is within normal, because normal is up to 45 millimeter mercury. طبعا this patient has metabolic acidosis because his bicarb was low. Along with the metabolic acidosis, he also has dehydration and renal failure. So why does that happen؟ يعني ايش الفكرة انه those patients who are newly diagnosed with type 1 or who are type 1 and they are not compliant with their medications basically might go into this emergency of diabetic ketoacidosis. So what happens is, it's all comes back to one hormone, which is the insulin. So if you look at the effects of insulin, which are important and can come into your exam. So the insulin increases the glucose uptake and glycogen synthesis في liver وفي muscle. And also it is responsible to increase the glucose uptake at the adipose tissue and decrease the breakdown to fatty acids. So because of such condition, when the insulin increases the glucose uptake. So when I say glucose uptake, basically the glucose is being entered inside the cells through the GLUT receptors. And when that happens, basically لما الجلوكوز بيدخل جوة الخلايا, the whole cycle starts, which you took in biochemistry, the cycle of ATP synthesis. And this is how you get the energy. We do not eat food just because we want to eat food. We eat food so we can get energy, so we can work hard. So that's why this it's a message for those students or even anyone in the public who's only eating one meal per day and they want to perform normally throughout the rest of the day, unless they are doing intermittent fasting, which is being done under supervision of someone who is specialized in this matter. It should not be the way that those who are only eating one meal per day, they are actually harming themselves more than benefiting themselves. So insulin's there to increase the glucose uptake because you're going to need this to create energy so you can study, you can work hard, you can work out, you can walk, you can think, you can memorize, and all of that. So when there is no insulin, what happens is the opposite completely. The glucose levels is going to go up. So when there is no insulin, the opposite happens, which is gonna increase in gluconeogenesis and increase in glycogenolysis, which both of those are usually suppressed by insulin. And that leads to the hyperglycemia. صح؟ والhyperglycemia eventually will يعني blood glucose at certain threshold, the body is gonna make the patient go and pee, so it will be in the urine as a glycosuria, and with continuous micturition and polyuria, the patient is going to develop the osmotic diuresis and loss of water and electrolytes, which leads to dehydration. Now, one thing I told you here is the insulin at the level of the adipose tissue, it decreases the breakdown to fatty acids. So it helps to storage of fat. Fat is stored in the form of triglyceride, and it decreases the breakdown to fatty acids. So when there is no insulin, so that like patients with DKA or type 1 diabetes, هيكون في increase في free fatty acid synthesis through the breakdown. And eventually increase free fatty acid synthesis. The breakdown will lead to the development of ketones, and that will lead to acidosis. Eventually they will have metabolic acidosis by decreasing pH, increasing glucose, and increasing ketones. So absolute or significant lack of insulin, increased breakdown of fat in adipose tissue, as I explained earlier, lack of uptake of glucose, increased hepatic gluconeogenesis, hepatic conversion of fatty acids to ketone bodies, and decreased hepatic glycogen synthesis. And this was the pathophysiology why this happens in terms of the يعني اللي هو ketoacidosis. Why would a patient with type 1 diabetes or insulin deficiency can develop diabetic ketoacidosis? Now, the DKA itself, in terms of the diagnosis, has three levels or three stages: can be mild or moderate or severe. So usually, alhamdulillah, I have not seen many cases with severe DKA where the pH is usually less than 7 or less than 6.9. And, the survival rate in such patient is pretty low. So alhamdulillah معظم الناس بتجيهم الأعراض, and alhamdulillah إنه they seek the medical advice when they are in the mild to moderate category. طبعا you can see that in severe DKA the bicarb is much lower, is less than 10, and so on. So one of the most important things, and I was just teaching the fourth-year medical students today about a case of sickle cell anemia, which has nothing to do with DKA, is really when we take history, when we try to ask patient question, and this is something you're going to do it next year, is we try to understand what, okay, we understand, we learned about the symptoms. البيشنت جاي بيشتكي عنده تبول كثير، بيشرب مويه كثير، وزنه نزل. But the important thing to understand is really what is the precipitating factors that led this patient to go into DKA. So did this patient had any sort of infection, sore throat, pharyngitis, UTI, pneumonia, or this patient is already known to have type 1 diabetes, ولكن ما كان compliant with medication, did not take their basal insulin last night. Believe it or not, in Saudi Arabia, I have seen patients with, going to DKA because they really, they don't want to live at home. So they prefer to go into hospital because they don't like their home environment. So they stop their own insulin use and they get themselves into DKA. And unfortunately, they require ICU admission. I have noticed in the last 7 years, unfortunately, 2 patients who actually, one of them was suicidal, was stopping the insulin because they want to die, and the other one, unfortunately, did not like her home environment, and she passed away and in the ICU because she stopped her insulin, and she was only 16, 17 years old. So the reason I'm saying this, that's not always the precipitating factors and who a patient لازم يكون عنده some sort of infection or dehydration to go into DKA. There might be some other psychosocial factors that we need to sometimes talk with our patients about, the home environment, the social factors, their relation with their siblings, relation with their parents, any issues at home that might be contributing to those recurrent DKA. So other factors which can contribute to the DKA, for example, patients who are taking new medications and they did not tell their doctors about, if they are abusing drugs, if they got pregnant, they did not inform the doctor to change their medications, and so on. So DKA, as I explained earlier, is a medical emergency, and I taught you how to take a good history. These are the major things for the history. What are the precipitating factors? What kind of symptoms they have? And then I would do the assessment using the ABC method and ask about the precipitating events. Now, in physical examination, as we saw that guy initially, basically there are some signs of volume depletion. I know هذا الشيء, it's very important. It's kind of, when I go into the case of DKA and I ask the students to examine, the students go like, what should I examine? صح يقول لك should I do an abdominal examination? Should I do a cardiac examination? And what should I examine? And when I say like examine things related to the DKA. So when you find a patient coming to the ER with DKA, the things you really want to rule out in terms of examination is, first thing is the signs of dehydration. So for example, skin turgor, and I think you know what skin turgor is. Look at their oral mucosa, look at their JVD pressure, look at their heart rate, the blood pressure, the capillary refill. All those things can indicate the volume depletion. And of course, when we are talking to the patient, you might, and غير noticing the breath the patient takes, you might want to also smell a fruity odor. Basically indicates يعني هو تقريبا fruity odor, which is similar to the odor of nail polish remover, and that indicates the patient has developed DKA. Fever is also a sign. Sometimes patients present with a fever, sometimes they cannot present with fever. As I said, yani, when you see such a patient in the ER lying with such kind of symptoms, and you talk with the family, they're telling you this story. The first thing you should do is really the finger stick glucose, and this should be even as important as you are checking the vital signs. And then if you see it high, the next thing you should do is the ABG or VBG and urine ketones, and طبعا start the patient on the insulin. What about the non-ketotic hyperosmolar hyperglycemic state? So basically, the onset is a little bit different from DKA. DKA is kind of يعني acute. Can happen within few days. ولكن ال HHS, it can take several weeks and even months sometimes of patients going back and forth with polyuria, polydipsia, losing weight, not مش لازم losing weight. Those patients might develop fatigue, lethargy. يعني موضوع seizures or neurological deficits kind of rare. يعني the most important thing يعني in terms of the clinical history to differentiate اللي هو hyperglycemic non-ketotic state, those patients usually do not have the nausea, vomiting and abdominal pain. الكيتونز اللي موجودة في الكيتو acidosis, that's what causes the abdominal pain. So the HHS, usually those patients will have the history of catabolic symptoms اللي هي polyuria or polydipsia or weight loss, which is lasting much longer, مش والله 1 week ولا 2 week, that lasting much longer. And they will not have the acute nausea, vomiting, and abdominal pain, just to differentiate that. And some of those, the kind of very severe, especially if an old group of patients might develop confusion or delirium. طبعا they present with dehydration, hypotension, tachycardia, and so on, similar to the DKA in terms of the physical examination to a certain point. بس طبعا ما حيكون عندهم الأسيتون breath. This is just a quick comparison in terms of the اللي هو lab difference in terms of the DKA versus the HHS. I think it's important. The most important difference you would like to notice is the bicarb. In the bicarb, because of ketoacidosis, is quite low. في ال HHS is going to be normal. طبعا الكيتونز سواء serum or urine is going to be completely positive for DKA. هنا غالبا ما تكون موجودة، أو حتى لو موجودة حتكون very small. And this is a mistake. يعني sometimes للأسف الشديد أشوف مرضى كثير في عيادتي يعني they were told that they had DKA and they were admitted even to ICU على أساس إنه كان عندهم very small increase في الكيتونز, but they did not have they had a normal pH. So they had basically a hyperglycemic state, non-ketotic. And sometimes هذه طبعا مشكلة. البيشنت يدخل الاي سي يو لمدة يومين ثلاثة ونكتشف انه اصلا كل التشخيص حقه كان غلط. So it's very easy to diagnose. It's not يعني it does not take يعني that much reading even. يعني anyone يعني you as a student, if you just memorize this slide and you understand the concept, الفرق ما بين ال DKA وال HHS literally is the serum bicarb. إذا كان serum bicarb is normal, so this is not a DKA for sure بإذن الله. When we want to manage both of those conditions, so on a DKA or an HHS, it really is the key at the management. يعني في لها ثلاثة أسس. الأساس الأول dehydration should be managed with rehydration. الأساس الثاني اللي هو insulin, because you cannot just give them fluids and they still have high blood sugar, so you really need to manage them using insulin and using an insulin drip with certain protocol dedicated for DKA. Now, you might want to also closely look up the potassium while we are managing with fluids and insulin. And if you remember, the two patients I told you about who passed away in the ICU, young girls passed away in the ICU with DKA, mainly because their potassium was not managed well. What happens is when the patient presents with DKA, is if you remember the guy I presented, his potassium was slightly elevated. So usually when those patients receive insulin, the potassium is going to go inside the cells, and that will lead to severe hypokalemia, which can trigger arrhythmias, which basically triggers VTAC and VFib, and they pass away. This is why those patients usually needs to be monitored very closely في ICU, and their potassium and glucose level needs to be checked every 2 to 3 hours. And then, of course, we treat the underlying cause. If we see, for example, patient going into DKA or HHS because of some sort of method infection, لقينا في UTI, لقينا في pneumonia, then we should treat the underlying cause. So fluids is the first thing usually, and fluids cannot be given by mouth. So the patient needs to have a good IV access. If the kind of patient drowsy, was severely dehydrated, وما لقيت له IV access, then a central line needs to be inserted. طبعا we have to be careful يعني حتى ال fluid, how should we give it, and there is a protocol for it موجود على up to date, and I can share it with you, even the article about the emergencies, that there is a way we should give fluid. We have to be cautious, because if we give that in a very quick and excessive way, then we might increase the risk of acute respiratory distress syndrome or even cerebral edema, especially in kids. This is just an example of the suggested flow sheet where the patients basically, and you're gonna see that even in emergency course, I think in 50 year, again, where in this sheet where you have all the data of the patients. You're gonna have the date, the vital signs, the serum glucose, the ketones, the electrolytes results. طبعا هذه الآن صارت كلها electronically, but I think this is even for the nurses. لأنه يعني at ER the patient's values were this, and then for example when you receive the patient up in the ICU, let's say 4 hours later, then you have to do the values again, and then every 2 hours. And this is the reason why the patient is in the ICU, because potassium or bicarb or glucose needs to be monitored every 2 to 3 hours. So usually when we start with the fluids, we usually start with the normal saline, and then you know, the reason why we give normal saline is because it has the amount that is very much similar to the body fluids, and then we switch to the half normal saline if the patient's sodium is really elevated. And there is a rule that usually يعني we switch the fluids, and fluids continuing، ولكن من النورمال سلاين احيانا نحولهم الى D5. تيجي تقول له طب دكتور البيشنت ان DKA والبلاد شوجر عاليه وداخل في اسيدوزيس، ما هو معقول انا اعطيه dextrose. Yes, we give them dextrose because we don't want their blood sugars to fall very quickly. So we kind of manage giving them the normal saline, and after that switching them to D5 normal saline, just to avoid the quick drop down in their blood sugars. And then, as I mentioned earlier, really we have to monitor the potassium very carefully. It should not drop between below 3.3. You don't need to memorize this at this moment. In my opinion, the initial fluid is the normal saline, 15 mils to 20 mils per kg per hour, about 1 to 1.5 liter in 1 hour, and then 500 liter in the next 2 hours if the patient is in shock, and then ممكن 250 cc according to the hydration status. This is just an example of how we start the fluids. What terms of the insulin, usually we give the low dose 0.1 units per kg per hour. Usually it's in the insulin drip. يعني زي ما بنعطي saline normal saline through the IV line, there will be another IV line where the insulin is being given to the patient inside a drip. So what's the aim for drop in the blood sugar? It's around 50 to 70. ما نبغى نفجع الجسم فجأة متعود على 400 500 600 القراءات وفجأة نخليها 100 في خلال ساعة. This is not good. The patient is not gonna like this. The insulin usually we give, يعني إذا كان patient in severe DKA, usually we give IV drip, especially if the patient is severely hypovolemic. And once the acidosis resolve، يعني احنا الآن متابعين على الشيت اللي وريتكم هو بالنسبة للبايكارب values. So once the bicarb improves and the acidosis resolve, we overlap that insulin with the subcutaneous shot, and then we allow the patient to eat. Just gonna skip this. So this is just and briefly what do we mean by resolving the DKA. So if the anion gap is less than 12, pH is improved, bicarb is more than 18. For the HHS, if the osmolarity is less than 320, and then gradual recovery to mental status. So the key, as I said, in DKA, when we are the initial management will acute management using the fluids, insulin, and potassium. ولكن the key is to prevent another DKA, and it is regarding the patient education. Type 1 diabetes is all about patient education. And really, those patients, and we need to understand, sit down with them and understand what are those precipitating factors and what can we do in terms of helping those patients to prevent those from happening again. Briefly, hypoglycemia is, is the third emergency I would like to talk with you about. If we want to memorize or, what kind of symptoms those patients have, we can use the mnemonic tired, which includes tachycardia, irritability, restless, excessive hunger, diaphoresis, depression. Now, among those of you who are eating only one meal per day, check it out if you have any of those symptoms. So sometimes when we are hungry or sometimes when we're trying to go out to buy food and our bills get late or our food that we would like to order is not there, we kind of feel the hypoglycemia. This is because the moment you start thinking about food, subhana rabbil alameen, your saliva, just the release of your saliva, لعابك بيسيل سبحان رب العالمين انه الانسولin starts to get secreted from the pancreas. So hypoglycemia is an emergency. It's as we said, the glucose is an obligate metabolic fuel, and we understand that the only source of energy for the brain is really the glucose. So hypoglycemia is not good. And usually when patients go into hypoglycemia, usually في وسائل دفاعية counter regulatory hormones خلقها رب العالمين to increase the glucose values inside the blood, which includes the release of catecholamines, glucagon, growth hormone, and cortisol. But some patients lose that counter-regulatory hormone mechanism because of their disease. And so they might go into severe hypoglycemia and that counter-regulatory mechanism will not be activated. And this can lead to severe hypoglycemia, even lead to loss of consciousness, altered level of consciousness, or even seizures. If we want to divide the symptoms of hypoglycemia, طبعا احنا ذكرناها بصفة عامة، ولكن يعني non-specific symptoms can be nausea and headache، ولكن symptoms يعني if you want to do it pathophysiologically can be either autonomic or neuroglycopenic. Autonomic symptoms, which includes the sweating, anxiety, hunger, pounding heart, trembling. I usually call those the symptoms that the students get before the exam. So if you don't want to remember the symptoms of autonomic or symptoms of hypoglycemia, is the same symptom that you might want to, يعني إن شاء الله رب بعيد الشر عنكم, but you might experience such symptoms before an actual exam, just because your autonomic nervous system is activated. Now imagine this is happening with the one meal per day what you're eating. So this is not good. You need to go to the exam with your stomach full. With the neuroglycopenic symptoms, basically those patients will develop يعني اللي هو advanced stage where they have difficulty in concentration, confusion, weakness. They will not be responding back to you. And those kind of symptoms will be severe and they need to be treated immediately with carbohydrates. So this is how, what happens in terms of, I told you the counter-regulatory hormone response when the blood sugar drops. The blood sugar drops is, from 82, there will be inhibition of endogenous insulin secretion. When the blood sugar reaches 70, على طول الجسم يبدأ counter-regulatory hormone release, catecholacogon, catecholamine, cortisol. 50 to 60 the onset of autonomic neuroglycopenic symptoms. يعني كل هذه الأمور تبدأ تحصل والمفروض أن المريض يحس فيها قبل ما يوصل لمرحلة loss of consciousness, which can happen basically when the blood sugar reaches below 40 to 30. So the Whipple triad is something that we usually use in history. Yani when the patient comes in, and this is a very common practice in common presentation in the outpatient clinic, endocrine clinic, when the patient comes in and saying, "Doctor, يعني دائما يحصل عندي هبوط." So I have to make sure that what they are talking about is true. فأول حاجة I ask them about the symptoms, and we have just learned about the symptoms of hypoglycemia. And then after that, I ask them when they feel those symptoms, do they actually check their glucose values? And if they said no, so their symptoms might be anything other than hypoglycemia. So the symptom has to go with low glucose concentration. And the third thing, that their symptoms should be relieved when the blood glucose is raised. يعني مثلا يجيني مريضة ومريض يقول لك أنا عندي دائما هبوط في السكر متكرر، أجي أسألهم عن الأعراض تطلع أعراض قريبة من أعراض الهايبوغلايسيميا، أجي أسألهم عن البلاد شوجر أثناء الأعراض هذه ما بيقيسوا، فكده غلط. هذا أقول لهم الأعراض حقتكم ما لها علاقة unless we know أنه you have a low blood sugar. طيب قالوا والله قسنا البلاد شوجر ولقيناه 70، هو ما هو low, it's borderline صح؟ low blood sugar is below 70. سو لقيناه 70. طيب انت اكلت حاجه راحت الاعراض؟ لا والله ما راحت الاعراض. طب معناها انه الاعراض دي ما كان لها علاقه بالايش؟ بالهايبوغلايسيميا. and this is what we call the Whipple's triad. There are other reasons يعني other than insulin والdiabetes for the hypoglycemia, which basically includes Addison's disease, hypopituitarism, renal failure, hepatic failure. Some drugs like beta blockers, ethanol, اللي هو الalcohol, hypothermia, and so on. Some patients, unfortunately, can present with tumors like insulinoma. They might be abusing drugs like insulin and sulfonylurea, and they might be causing the hypoglycemia. So urgent treatment is necessary in patients with suspected hypoglycemia. Blood should be drawn, and طبعا احنا ما حنستنى البلد انه يجي، ولكن usually we check the glucose. If the glucose is low, then we should treat them. Now, if we get a patient that is having frequent hypoglycemia and this patient is not on insulin, then this patient needs to be admitted to the hospital for 72 hours observed fasting. يعني نخليهم في المستشفى لمدة 72 ساعة، يعني 3 أيام فقط. هي المفروض انها تكون observed fasting. The only reason they should be in the hospital because we need to catch them when the low glucose happens, and at the same time when the low glucose happens we need to withdraw the blood for insulin, C-peptide, and other hormonal levels to confirm that this is a real hypoglycemia, to go on from there. So treatment for the hypoglycemia, يعني if the patient conscious طبعا احنا نعالجهم بال 15 to 25 grams of carb. If the patient is unconscious, then usually they need something like a glucagon injection, which is intramuscular injection. Usually we teach the patient's family, especially the type 1 who are taking huge doses of insulin, how to give that intramuscular injection of glucagon. Now, if the patient is in the ER or you don't know how to do at home, أقل القليل حطوا عسل على الفم على الشفايف. حاول إنه يكون البيشنت شوية واعي عشان يقدر يشرب مثلا موية بسكر وما إلى ذلك. طبعا if all this is not possible, then you have to wait for the الهلال الأحمر عشان يعمل IV line to give the IV dextrose, so on 25 or 10%. As we said in DKA, is really the aim is to prevent and treat the underlying cause. If the patient has, critical illness that's causing this, then we should treat that. If the patient is taking their insulin and they are delaying their food for a very long period of time, then we should educate them about this. Maybe the patient diet is so bad, or maybe the patient is taking huge doses of insulin and so on, or they're going on sleeping without even eating anything. So we have to educate patient to prevent further episodes of hypoglycemia. In terms of the emergency, hyper and hypo both are dangerous, ولكن hypo can be much more dangerous than hyper. So for hypoglycemia, blood sugar is less than 55, طبعا, which does not have an explanation on the floor or ER. We should, as I said, order the glucose, insulin, C-peptide at the same time when the glucose is low. So in summary, these are the 3 diabetic emergencies with in terms of the symptoms, respiratory, cardiovascular, nervous system symptoms, and so on. And by this is my last slide. Thank you very much, and I'll be more than happy to answer any questions into Endocom, and this is my email if you have any questions. Thank you.
يعطيك العافية
يعطيكم
دكتور.
العافية يا دكتور.
Like, if you can just wait, so I can just take the picture for the attendance. Is that leaders ممكن يقولوا لي هل المفروض أنا آخذ picture ولا أنتوا عندكم بتاخذوا الصورة بالنسبة للأتندنس؟
لا العادة ما نعمل شي زي كذا.
يعني ما فيها attendance.
لا
لا ما في.
Okay, great. Okay, if you have any questions, I'll be more than happy to answer.